Good morning, madam. Apart from the fact that there are membranes that form between the cornea and the iris at the anterior chamber. So we'll first deal with uveitic anterior synechiae, and we know that uveitis, there are numerous mechanisms that can cause glaucoma, but we are interested in the peripheral anterior synechiae because that's where the anterior pull mechanism comes. And why does this develop? It occurs because of breakdown in the blood aqueous barrier, which causes inflammatory mediators, fibrin, and other mediators to accumulate in the iris, which causes swelling and stickiness of the iris. And when that happens, the iris tends to stick to whatever is close to it. Most commonly, the anterior lens capsule, but also in the peripheral cornea. So this mostly occurs in the inferior angles because the mediators gravitate inferiorly and the aqueous is most plasmoid at that point. This can also cause secondary vascularization. Now, regarding treatment of uveitis with glaucoma, one important thing to note is that you have to treat the uveitis depending on its merit. So, don't scrimp on steroids thinking that that might increase the intraocular pressure and worsen the glaucoma. So, you have to manage glaucoma separately, give full treatment for the uveitis. Of course, you can use immunosuppressants or modulators if necessary. Aqueous suppressants are the mainstay of treatment, and other medicines like prostaglandins and pilocarpine are best avoided unless you are dealing with burnt out uveitis and you are dealing only with the sequelae. Surgical approach in an active uveitis is rarely needed because the IOP production itself becomes low, and the IOP is usually low in cases of uveitic glaucoma. So, uveitic conditions. So, this is a video of a gonio done in a patient who has recovered from uveitis. The inferior angles, you can see it's all cluttered with pigments and clumps, and fortunately the PAS has not developed, but you can see how bad the angle becomes following a case of uveitis. Coming to the next important group of problems in this anterior pull mechanism is neovascular membranes. Now, the most important thing is it has to be recognized early, because it's usually a secondary problem, retinal disease or vascular insufficiency that causes new vessels to form. And patients sometimes present like a case of acute anterior chamber, acute primary angle closure glaucoma. So they have steamy corneas, sudden loss of vision, raised IOP, vomiting, eye ache, headache. So always differentiate the primary angle closure disease from neovascular membranes. And this you could ask for the history, because there may be history of retinal problems earlier, but also the anterior chamber is typically deeper in such a situation, while in we know that acute angle closure glaucoma, the anterior chamber has to be shallow. You can take cues from the other eye also. Initially the angles may be open, which is when you have to catch these patients, because otherwise it becomes a headache for treating the glaucoma part. Because later it closes like a sheet, and even if the vessels regress, you still get glaucoma due to peripheral anterior synechiae. Treatment is for the primary cause. Anti-VEGF injections, they provide a window of opportunity for you to do TRAB, as well as for the retina person to do their laser or whatever they want to do. So anti-VEGF injections are very helpful in this sort of situations. As previously mentioned, the vessels might regress, but the membranes may not, depending, and they may cause permanent angle closure glaucoma. So this is a post-CRVO patient. You can see very fine new vessels here. So these should not be missed. Sometimes they go directly to the retina consultant, dilate in a dilated state, and they may miss it. So always be on the lookout for new vessels at the iris. This is the gonio picture of the same person. My PG took only 2 gonio pictures. So this is the vessels at the inferior angle in the right eye, and this is post Avastin injection. You can see that the inferior angles have, the vessels have gone, but all the angles have closed. So this peripheral anterior synechiae formed due to new vessels at the angle. Coming to the next important group of conditions, the iridocorneal endothelial syndromes. Now, the named variants are the Chandler syndrome, which is the most common, usually affects the cornea, progressive iris atrophy, and iris nevus syndrome. Usually in middle-aged women, men also might get it, but almost always unilateral. And this is characterized by an epithelium-like membrane that spreads from the cornea around the angle onto the iris. So epithelium-like because they are actually endothelial cells with epithelial characteristics like desmosomes, microtubules and filaments. So they have a property to migrate, which is highly unlike the endothelial cells. And these migrate as a sheet posteriorly from the corneal surface. Now the characteristic appearance is of a hammered silver appearance of the endothelium, and this is very pathognomonic and has to be looked for. So this is a specular microscopy feature. You can see the left eye is normal, typical hexagonal monosheet of endothelial cells, while in the other eye you can see the cells are ill distinct, they have lost their shape, and you can't really count the cells. One of our patients with Chandler syndrome, seen just a photo like this, you can't really make out what problem this is, but the other eye will be normal, and you have to rule out other causes of corneal edema. This iris atrophy, now this is very glaring, like you can't miss this sort of a picture. Also, all the problems of iris atrophy are there: correctopia, dyschorhea, melt holes, stretch holes, polychoria, all that. And this is the other eye of this same patient. Now, coming to the other variants, sometimes it may be very, very subtle. Like this patient, the right eye, you can just see a small dyschorhea, small peaking of the pupil inferiorly, and if it is dilated, you might even miss that. The other eye is normal, but you have to be careful while examining a cursory examination, and you might miss this, and the patient might come back years later with severe glaucoma. This is a hammered silver appearance, so this is pathognomonic and can be seen on the affected side. Another very subtle case of iris changes. I have explained this before. Two patients with the similar findings on the endothelium. Now these two photos are of the iris nevus syndrome. These are taken from the net. I didn't get a proper one. So the lighter colored areas are the areas which are abnormal. This is a sheet of abnormal endothelial cells that are spreading onto the iris from the corneal endothelium. And the darker areas, the islands, are the normal iris tissue which are getting pinched up from the surface of the iris. So this causes nodules to form, and this is pathognomonic of this sort of condition. It pulls the pupil down, and you can see some ectropy on UV also. Epithelial ingrowths, these are now rather uncommon following proper microsurgical techniques that we have now, but they can occur following trauma, difficult surgeries, and very painful condition. Lots of inflammation. Epithelium membrane forms, they grow through the wound, and they give a typical scalloped appearance growing in from the limbus. This is a less common, this from the net, less common cystic type of epithelial ingrowth. These are more localized, and they are probably easier to manage. Now surgical modalities are required for treatment of glaucoma in these conditions, and even surgical modalities might fail because the epithelium keeps on growing over the internal ostium. Coming to anterior segment dysgenesis, these are classified as secondary childhood glaucomas. They are autosomal dominant with high penetrance, but the expressivity is variable. So you might get one generation with severe iris changes, and the next generation may not have any too much of them. Typically bilateral because they are genetic. There are numerous conditions involved in this, but we will focus on axon-filled rigor because that's where the peripheral anterior synechial are most common. So so this is a gonial photo of a few of the iris membranes that are forming onto the Schwalbe's line. Coming to axon-filled rigor syndrome, axon-filled anomaly is an anteriorly displaced thickened Schwalbe's line. Sometimes they even they are displaced into the anterior chamber. They float into the anterior chamber. and there are always adherent iris strands pulling it downwards. Rieger's anomaly is a congenital iris hypoplasia. They may be associated with correctopia and polychoria, and if they are associated with systemic findings, you will get dental or facial bone defects, umbilical hernias, and pituitary involvement. It's a heterogeneous group of mutations, mainly 3 types, and around 50% of such individuals can get glaucoma. There is a monolayer membrane of endothelium-like cells in the angle, and glaucoma usually occurs in adulthood because of incomplete development of the trabecular meshwork. Now, some of the patients may have very severe iris changes, but the glaucoma may not correlate with those changes. Others have very subtle findings, but the glaucoma may be severe. So, again, few patients with prominent Schwalbe's line. Yeah, you need, as in any childhood glaucomas, you need to manage it surgically. So, in conclusion, various conditions having the same features of the angle closing, peripheral anti-synechial, secondary. The clue lies in the cornea and the iris. So, be careful. I mean, you have to counsel the patient that they may develop glaucoma later on. And in case of NVI, you need to manage it aggressively with your retina consultant. Thank you.
Thank you, Abhilash, sir. Sir, what about this peripheral anti-synechial? Can you break it with lasers?
Pardon?
Laser gonioscopy,
No,
gonioplasty.
I
don't try
don't
it.
think so. No, I'm not tried that. I don't think that's once the membranes are formed, they are rather thick. You'll be hitting on the iris and burning the iris rather than doing anything much.
I don't think.
Now with the advent of goniotomy and all, maybe one can try.
Surgical gonioplasty is there, where we put visco and then try to push the iris backwards. But it mechanically opens the angle, but pressure-wise, I don't think there is a big difference.
Because that will incite some amount of inflammation anyway. So that will again go and stick back.
Trabecular resistance still persists even after mechanically opening up the angle.
Yes, damage to the trabeculum also.
Okay. Thank you, sir.
Thank you.